Everyone. This lecture is about um, the gallbladder and biliary tract, or you can say the gallbladder and the extrahepatic biliary system. Why we are saying extrahepatic? Because inside the liver there is also um, the ducts, but what we will be studying in this one is outside the liver, so that's why it is extrahepatic biliary duct. So biliary tract, if we will talk about the anatomy, there is intrahepatic duct. There are two left and right hepatic duct, and like of course, then they make small branchings inside the liver, which basically collect the bile, and then they make together. And what happens is uh, the extrahepatic duct. There is a left one, and then there is a right one. And if you can see like the size of both of them, they are written, though it's not important to remember the size and all these things, but the important thing to know is that the common hepatic duct, which is formed by the combination of these two, and this is the common hepatic duct I'm talking about. And what happens is like the gallbladder, which is attached down to the liver, it also gives a duct, and both of them they combine together with the common hepatic duct, and they make a common bile duct. Okay, so now um, I will show you more photographs for this thing to make you understand. Okay, so the gallbladder is like it is under the liver, and um, now the anatomy of the extrahepatic biliary system is very much different in different individuals. But right now, what I'm talking about is the gallbladder. See, the gallbladder is a pear-shaped organ, as you can see over here. It's around 7 to 10 centimeter long, and the capacity is around 30 to 50 milliliter. So this is the anatomy of the normal gallbladder, but you know, in most of the conditions like bile duct stones and all these things, what happens is the gallbladder uh, can distend or can increase in size or can swell up. So in that case, it can reach up to 300 milliliter of uh, what you can say size, or it can contain around 300 milliliter of matter or fluid. So now the gallbladder can be divided into four anatomic areas. One is the fundus, the body, the infundibulum, and the neck. The infundibulum is also called as the Hartmann's pouch. And the fundus, or the tip, basically protrudes from the anterior edge of the liver, and there is the point where basically when you will touch, the patient may feel a pain. So the gallbladder contains smooth muscles, and now other than this, the important things to talk about, is the cystic duct. So the cystic duct is around 2 to 3 centimeter long. There is a valve which offers some resistance to the bile flow. It enters the common duct at an angle of 75 degree. Uh, no, sorry, at an angle like in 75% of the individuals, because not, I told you, not in everyone like they have the same anatomy. And in the rest of the people, it runs parallel to the hepatic duct or winds around before it joined the common duct. Okay, so this anatomy is different in different people. For example, you can see this one, like uh, you can see this one is spiraling around. Okay, so like different people, they have different anatomy uh, of these ducts. So simply, the extrahepatic bile ducts consist of the, as I told you, the right and the left hepatic ducts, and then there is a common hepatic duct. Okay, the cystic duct and the common bile duct. Okay, and the common bile duct, as we know, that it enters into the second portion of the duodenum. Uh, we call it as ample of Vater, or we also call it as sphincter of Oddi. Okay, so this thing now, this one is triangle of Callet, a space of cystic duct, common hepatic duct, and inferior margin of the liver. So this one, and this one, right? So what's included in this triangle of Callet? Like there is a cystic artery. Now cystic artery supplies the gallbladder, uh, and it is usually a branch of right hepatic artery. So now this triangle of Callet is the one in which like you will find the cystic artery. So simply when it reaches like to the neck of the gallbladder, it divides into the anterior and the posterior division, and the venous return from the gallbladder through the small veins enter directly into the liver, or sometimes there is a cystic vein as well that carries the blood to the portal vein, and then the portal vein drains into the liver. So there is a lot of what you can say variations in the anatomy of this thing. Okay, so and there is a lymph node also located here in this triangle. Okay, which drain this area. So again, like this is a thing which is showing up the relationships. You can see the variations, okay, of this. So in very simple words, that there is a lot of variation in the anatomy of gallbladder, the ducts, the cystic artery, and all those things, right? So gallbladder is also supplied by the sympathetic and parasympathetic nervous system. Of course, the parasympathetic comes from the vagus, whereas the sympathetic comes from T8 and T9, preganglionic sympathetic level from the T8 and T9. So the length of the cystic duct is quite variable in different people. It may be short, it may be absent, or it may be high, it may be long, it may run parallel, it may spiral around. Okay, so sometimes it runs as far as to the duodenum. So there's a lot of variation simply. So sometimes, the cystic duct completely runs along with the hepatic duct and until it reaches the duodenum, and then it makes one. So the common bile duct is around 7 to 9 centimeter long. Okay, now different books give like maybe you will found 7 to 11, maybe you will found 7 to 10. So simply you can remember 7 to 10 centimeter long and 5 to 10 millimeter, or you can say zero point 0.5 to 0.10, 0.1 millimeter centimeter, to 1 centimeter in diameter. And in the hepatoduodenal ligament, the hepatic artery is to the left of the CBD or common bile duct, and the portal vein is posterior and medial. And now the main pancreatic ducts join the CBD to form a common channel along 1 centimeter long, and then of course it enters the duodenum. For example, you can see this one. This is the duodenum, this is the gallbladder, okay, and the infundibulum, the neck, and see, the duct is passing, common hepatic duct is coming, they make together the common bile duct. It is joined together with the pancreatic duct, and ultimately they open up in the second part of the duodenum. So this is how they are formed, and this is the anatomy. So now, uh, so see, there is a lot of variations over here. Different people, they have different anatomy. There's a lot of variation in the artery which supplies the gallbladder. Even there is a lot of variation over here. For example, in most of the people, these two ducts, they unite outside the duodenal wall, but in around 20% of the people, they join within the duodenal wall and have a short or no common duct. Okay, so the anatomy is quite varies even in this region as well. In very few people, like around 10% of the population, sometimes they both have different openings in the duodenum. So the sphincter here is called this is called as ampulla of Vater, and the smooth muscle around that is called as sphincter of Oddi. Okay, so this is how the things work. Now, again, like, see, you can see the gallbladder, you can see the cystic artery in this one, you can see the right hepatic duct, you can see the left hepatic duct, and you can see like this is the portal vein, and then they make common bile duct which is going all the way here, and the duct from the pancreas, they join together, and they are opening into the second part of the duodenum, right? So this is like the normal anatomy, or the variations in anatomy. So again, like they are showing you how different people, they have like different type of uh, variations, right? Okay, I told you the parasympathetic from the vagal, and there is sympathetic innervation as well, and it also contains motor fibers to the gallbladder and secretory fibers to the ductal epithelium, and sympathetic nerves mediate the pain of biliary colic. So like this. Okay. So now, what is the function of gallbladder now? The function of gallbladder uh, is basically it stores bile. I think it's too basic to talk about, but the liver is continuously producing bile, and and this bile is basically secreted into the bile canaliculi, and generally in adults, the normal adults, they produce around half liter to 1 liter of bile a day. And there are many things which play a role in the formation of bile, like there is a neurogenic response, humoral response, and chemical stimuli. For example, vagal stimulation produces bile. Okay, whenever the vagus, so same thing, uh, rest and digest, right? So parasympathetic outflow helps digestion. So whenever the parasympathetic outflow is increased, so what happens? It produces more and more and more bile. And also, like whenever we eat, the food uh, which is rich in proteins and fatty acids, so in the duodenum there is release of secretin, and that secretin also increase the formation of bile. So simply, when the bile is formed by the liver, it flows to the hepatic ducts, into the common hepatic duct, and through the common bile duct, and finally it goes into the duodenum. So this is how the things work. Okay. So basically, bile is made up of water, electrolytes, bile salts, proteins, lipids, and pigments, right? So, uh, and there is a lot of functions of that. If you know the function of the bile, like they are the one which helps in the digestion of the fats. Okay, so like there's no point to go into much details because otherwise all this thing details are going to take a lot of time, right? But in simple words, um, biles bile is formed, and if you know that there is a uh, um, enterohepatic circulation of the bile, the bile which is released, it is reabsorbed and it is circulated back, right? So now um, the function of the gallbladder and all those things is what? Like the gallbladder, the bile ducts, and the sphincter of Oddi, they basically act together to store and regulate the flow of bile. And the main function of the gallbladder is to concentrate the stored bile and then release that bile into the duodenum in response to all the things which increase or in which which demands bile. For example, again, eating the food or like fatty meal or proteins, right? So whenever someone is fasting, by the way, 80% of the bile is which is secreted by the liver is stored in the gallbladder, and that is simply regulated by a working sphincter of Oddi. This sphincter is contracted in state, so all the bile which is coming, it will be stored here in the gallbladder. Okay, and um, what happens in the gallbladder is basically it concentrates that bile, and how it concentrates, it basically reabsorbs the sodium chloride and water. Okay, and that makes the bile concentrated around 10 times more concentrated than what is basically formed by the liver. So now uh, what happens is, and whenever what is needed, what happens, like the bile which is stored in the gallbladder, it basically goes into the duodenum. So um, now you can see over here they have shown the picture, the percent of cholesterol and percent of sodium and percentage of lecithin. Okay, and there are different phases: phase 1, phase 2, phase 3, phase 1 and phase 2. Okay, so what happens is entire hepatic circulation is like the bile which is released into the intestines. It is reabsorbed and it is circulated back. You can see over here, bile secreted, released into the duodenum, and then it goes down, and much of that is reabsorbed, and again the liver will form bile again, and then the same cycle will run. It is called as enterohepatic bile circulation. Okay, so now, so the one first function of the gallbladder is storage, the second function of the gallbladder is concentration, and there is one more function of gallbladder which is secretion of the mucus. And that's the result because gallbladder also form mucus, so sometimes a mucocele can be formed in the gallbladder. Okay, so these three functions I'm talking about. Now, before going to talk about the you can say the abnormalities or the pathologies of the gallbladder, what are the investigations which are available to check for gallbladder things or gallbladder problems? What kind of tests are available? You can see like ultrasonographies can be done, and it is very specific, both specific and sensitive. It is very good in detecting the gallbladder stones, bile duct stones, dilation of the bile ducts, and the diagnosis of other biliary diseases like cholecystitis, inflammation, tumors, and malformations. So, ultrasonography. By the way, ultrasonography is the initial investigation of for any patient suspected with the disease of biliary tree. There are many good points here. Ultrasonography is, it's non-invasive, it's painless, and it can be performed in any kind of patient. So it's a very good examination, like a technique to look at the gallbladder, right? So stones can be catch, polyps can be catch. So even like the swelling of the gallbladder, like cholecystitis, can be seen on ultrasonography, right? So this thing can be done. Here there are some photographs of ultrasound of gallstones. You can see the gallstones over here in all this ultrasonographies. Okay, when it comes to the radiographies, a plain abdominal film can be done, and you can see over here. And gallbladder stones can be seen because they are radio opaque, and you can say like whenever we go and we do radiography, sometimes the center of the stone may contain radiolucent gas. Okay, so, and that's why we see uh, fissures due to that gas. That is called as the Mercedes sign. Okay, so other than that, uh, what test can be done is oral cholecystography. So this is the diagnostic procedure of choice for gallstones. But nowadays, this is not much done because this is replaced by ultrasonography. What they used to do is like they orally give radio opaque compound that is absorbed and excreted by the liver and passed into the gallbladder. And stones are noted on a film as a filling defect in visualized gallbladder. So nowadays it is not done much in any patient. Radioscopies can be done, for example, intravenous cholangiography. Okay, intravenous cholangiography. Okay, so uh, you can see as here that same thing. In that one, you were giving thing by oral, but here you will, of course, you will give intravenously, right? But the thing is same. Then there is PTC, which is percutaneous transhepatic cholangiography. And of course, like it is percutaneous, so it involves passing a needle into the intrahepatic ducts. Okay, so it is assessing or it is reaching the ducts percutaneously. So of course, like what they do is like they put a needle or a syringe percutaneously, and of course by ultrasonographic guidance. And once the position of the bile duct has been confirmed, they pass a guide wire and then a catheter over a wire. And through the catheter, they give some, what you can say, some contrast material. And then they take films, which is called as cholangiogram. Okay, so now this PTC or percutaneous transhepatic cholangiography has a very limited role in the management of patients with gallstone disease. But it is very, very useful in patients, for example, who have bile duct strictures or tumors. Okay, so this thing can be done. Other than that, I talked about this thing before, ERCP and MRCP. ERCP is endoscopic retrograde cholangiography. Okay, so ERCP, cholangio pancreatography. Now, the thing is simply, you know what is endoscopy? We pass something by mouth and we can visualize the esophagus, we can visualize the gastric area. So again, under that, by using that endoscope, what happens? Uh, they go into the common bile duct, or they can see the common bile duct. Okay, and then they put a cannula in that one, and then they give like some fluoroscopic material, and then they take the films, and that's why it is called as ERCP or endoscopic retrograde cholangiopancreatography, because once they reach that area and they uh, give the fluorescence, so see it is going opposite direction. Okay, so that's why it is retrograde. So of course, like they sedate the patient first, and but the advantages of ERCP is like the direct visualization of ampullary region and direct access to the distal common bile duct. Okay. Now, this test is rarely needed for uncomplicated gallstone disease, but for stones in the common bile duct, for example, in obstructive jaundice or cholangitis, this is a very good procedure because it is both diagnostic and therapeutic. Okay, like you can diagnose and you can treat at the same time. You can remove the stones, okay, because the endoscopic cholangiogram basically shows the ductal stones. So what they do sphincterectomy. They and then due to after sphincterectomy, they can extract the stones out. Okay, so uh, it have a very huge successful rate, especially if person, the doctor who is doing that should be expert. Okay, so that's very good thing about ERCP. It is very convenient or very good to remove the stones. So it is both diagnostic as well as it is therapeutic. So this thing is one of the thing. And then there's MRCP, which is magnetic resonance cholangio pancreatography. Okay. So now MRCP. If you know what is MRI, so MRCP is no different than that, but simply uh, MRI provide the details about the liver, the gallbladder, the pancreas, everything. Okay, so now uh, MRCP can be done. Of course, we need the MRI machine for that. Okay, and it can give a very good image of the gallbladder and the biliary system. The good thing about this one is it is a non-invasive type of test. A contrast is not required. Okay, and the images are very much clear. We can see the biliary tree, we can see any obstruction, we can see any strictures, and um, what you can say, uh, it is equivalent to ERCP. But remember, ERCP is a therapeutic type of investigation as well. It can remove the stones. Okay, so that's the good thing about ERCP. Okay, other than that, like they are showing the MRCP. Okay, so you can see uh, here they are using dilators of increasing diameter. Okay, there's an eyepiece over here. This is percutaneous one, transpatic. Okay, so of course, like by this way they can remove the stones. Okay, special examination, of course, like there is something called as HIDA scanning, HIDA scanning was one of the thing which is very of course it's radionuclide medicine, radionuclide scan. It's non-invasive. Again, it's non-invasive way to visualize or to see liver, gallbladder, and bile ducts. And the good thing, it tell us both about the anatomy and the functionality. So what they do, they give technetium 99M labeled uh, derivatives of dimethyl uh, dimethyl amino diacetic acid. Okay, so this is what they give. So they give this thing intravenously, which is cleared by Kupffer cells of the cells and excreted into the bile, and uptake by the liver is directed within 10 minutes, and the gallbladder, the bile ducts, and the duodenum can be visualized within 60 minutes. Okay, so this HIDA scanning can be done. So see, this is telling us two things. One thing, of course, it will tell about the anatomy. Second thing, because the Kupffer cells are clearing it up and the rest of the structures, they are taking it up within 60 minutes, so it will tell us about the functionality as well. So this is called as radionuclide scan. Kaleidoscope, again, uh, it's a small scope or camera, uh, and it can be used to visualize inside the tracts or the ducts simply. Okay, so that's all about the investigations which are available, about the introduction of the introduction, about the physiology, about the anatomy of the gallbladder and the bile ducts. And now uh, we will talk about gallstones. Okay, so gallstones are also called as cholelithiasis. Okay, gallstones are also called as cholelithiasis. Now, gallstones are very, very, very important. Why? Because they are very, very, very common, and they are more common in females. Okay, let me explain you a few important points about this one. Females are more commonly affected than the males. Okay, so now there are many factors which lead to formation of more gallstones. They say, like, remember 4 F's: fat, F for fat, F for female, F for 40, F for fertile. So they say, like, a fat 40ish or 40 years of female. So a female who is fat in her 40s and she's fertile. So they, whenever they have pain in the right upper quadrant, it could be gallstones. Okay, so very, very, very common. So the thing is, obesity, pregnancy, dietary factors, Crohn disease, for example, and gastric surgeries, and sickle cell disease, and thalassemia. These are all the risk factors of developing gallstones. And women's, they are 3 times more commonly affected than the males. Okay, so very, very, very common. And you can see over here the stone type. It could be gallstone stone, it could be pigment stone, it could be mixed. Pigment, of course, bilirubin and biliverdin. Okay, and gallstone stones, they are yellow, white, or gray in color, and they have indentation on them. They are firm with smooth or regular surface. Okay, so I will show you how gallstones look like. So cholelithiasis or gallstones. See, this is one of the gallstone. Okay, they are showing. This is a gallstone stone. So now the thing is how the patient present. Okay, how the patient present. Now, as I told you, typically patient present with pain, but this is not the most common presentation, because most patients, they remain asymptomatic. They do have gallstones, but they remain asymptomatic throughout their life. But some of the patients, they have some symptoms. And one of the symptoms is biliary colic. What is biliary colic? See, when the stone is obstructing the duct, is blocking the duct, so what happens is they have the pain. So now, due to that blockage, they can have complications as well. For example, they may have acute cholecystitis. They may have cholangitis. They even may have pancreatitis. Okay, they even may have pancreatitis. Okay, so first of the then as I think you will see is silent gallstones, asymptomatic. Okay, 20 to 40% patients. Whenever there is symptoms, they usually come after the meal. And what happens is, of course, there is some stone impaction, which increases the pressure in the gallbladder and the bile irritates the mucosa. There could be edema, there could be congestion, there could be exudation, which will result into acute cholecystitis. Okay, so see, biliary colic, right quadrant pain, intermittent colic referred to the right scapula or shoulder. This is very typical of the gallbladder pain, that it radiates towards the right shoulder. Okay, Now, if when they are asymptomatic, of course they are incidental findings. A patient went for ultrasonography and they say, okay, you have a stones. Okay. So now, very few patients they develop complications without previous biliary symptoms. I told you the name of the complications, right? And how the stones are formed, guys, simply uh, gallstones are formed due to the solids, you can say, the solution which is present in the gallbladder become solidify or it becomes solid. But they have the same thing: the bile, the bilirubin, the bile salts, phospholipids, and cholesterol. That's it. Okay. And in Western countries, around 80% of the gallstones are basically cholesterol stones, whereas 20% of the stones are basically black or brown pigment stones. Okay. But in Asian countries, both of them they are common. Asians can have cholesterol stones, or Asian may have the pigment stones. So now, whenever someone have pain in the gallbladder, we call it as biliary colic. It could be acute cholecystitis or it could be chronic cholecystitis. So, see, clinical manifestations of that's in gallbladder empyema, infection without infection, white bile, secondary CBD stone, and cholangitis and pancreatitis. It could lead to fistula formation. Okay, so the signs for acute cholecystitis is tenderness, guarding, large gallbladder, and positive Murphy sign. What is Murphy signs? You can see the YouTube when we do examination. We put a thumb or a finger under the what you can say the ribs, below the ribs, and we ask the patient to take a deep inspiration. And what they happen, like they feel a pain. That is called as the Murphy sign is positive. So now. Some of the people they do develop chronic cholecystitis, like around you can say two-thirds of the patients with gallstones, they present with chronic cholecystitis. What they have is like they have recurrent attacks of biliary colic, and the pain develops when the stone obstructs the cystic duct, which increases the tension in the gallbladder wall, so they keep on feeling pain. Okay, so and the chief symptom is pain in these patients. So it keep on increasing the severity, and the pain typically lasts for 1 to 5 hours. It is in the upper quadrant pain. It radiates to the uh, right shoulder or sometimes right upper back as well. So, and usually these pains come after the fatty meal or during the night after a heavy fatty meal, and the pain is episodic. Okay, so this is how they present, right? So now, uh, uh, of course, we will take the history, we will do the examination. And if you know these pet points, quite easy to remember, uh, uh, like how they present with. So anyhow, moving further, any patient uh, who have bile stones, okay, or sorry, gallbladder stones, so uh, they may have biliary colic or they may have acute cholecystitis, and that's why now all these things in surgery. There is a common topic called as acute abdomen. I think you have done in the previous semester. So acute abdomen, whenever there is any pain in the abdomen, that we go logically, we do the examination. We see either there is McBurney's point tenderness. We see like either there is Murphy point tenderness. So the differential diagnosis is quite long. Acute abdomen could be due to appendicitis, could be due to peptic ulcer, could be a pancreatitis, could be cholecystitis, and so on and so forth, right? So how we diagnose, guys, this gallstones is simply we take the history. In history, we ask for the pain, we check the pattern of the pain, the location of the pain, the radiation of the pain, the timing of the pain. We check either it's a male, female, fatty meal, whatever, like all the points we have discussed. So simply, of course, you will take the history, you will go for the physical examination, and then, of course, we will go for further investigations. For example, you can see over here they have done the gallbladder ultrasonography, and in this one you can see stones. Okay, so this is how we diagnose, right? So remember, gallstones doesn't means cholecystitis, but cholecystitis most of the time is secondary to gallstones. Okay, so gallstones can give biliary colic simply. So, of course, nowadays, the most common investigation to be done in these patients is, of course, ultrasonography and most commonly transabdominal ultrasonography. Of course, you have done all the investigations. I already talked about all the investigations. We can go for radionuclide scan as well. Okay, and whenever the Murphy sign is positive, remember it shows acute inflammation. Rest we can do a CBC. In CBC, maybe you will have a white blood cells count are more. Maybe you will found liver functions tests are a little disturbed. Okay, but of course they are not the diagnostic test, right? Rather, you can say ultrasonography will help you more because it will directly show you that there is gallstones. Okay, and once anyone is have what you can say uh, in many of the patients, when they have this attack, what happens is like they present with the pain, but in most of the patients, what happens is like the stone slip backs into the gallbladder and simply it will release the it opens up the duct, or it releases that pressure, and simply the pain is gone and the inflammation get resolved. But sometimes, when the inflammation does not get resolved, then this one empyema, gallbladder empyema can occur, right? So this thing. So now, uh, other than that, once the diagnosis is done, then of course we will go for the treatment. And how we treat, of course, any patient who is diagnosed with gallstones or symptomatic gallstones, what the doctors advise them is cholecystectomy, cholecystectomy, elective cholecystectomy. And of course, like it's not like this. Of course, like you will really relieve the pain of the patient. Elective means it's not an emergency procedure. Of course, you will ask the patient to avoid any fatty diet, avoid large meals, okay, and uh, pregnant women with symptomatic gallstones who cannot be managed with diet can undergo laparoscopic cholecystectomy during the second trimester. Okay, but uh, cholecystectomy now, uh, uh, of course, like nowadays, cholecystectomy is not anymore open surgery. Rather, it's laparoscopic done. Okay, so simply, most of the doctors they say like if the gallstones are asymptomatic, there is no need of cholecystectomy as well. Rather, they can just observe them and they can wait for the patients to develop symptoms or complications due to gallstones, right? Uh, but anyone who have symptoms or biliary colic or cholecystitis, of course, cholecystectomy is the treatment of choice. So now, whenever a patient comes and they have uh, biliary colic, you will give them painkillers like analgesics. You will put them nothing per oral. You will give them prophylactic antibiotics. Most commonly, broad spectrum are given. Uh, third generations are given with gram-negative cover like gentamicin, and they just wait like until the patient feel fine, and then they plan a cholecystectomy. So, of course, like now the question is about laparoscopic cholecystectomy or open cholecystectomy. That completely depends on the center. That completely depends on the expertise of the doctor, of course, right? Uh, that cannot be discussed over here, or of course, that cannot be shown. So, see, like here, there is written like indications of common bile duct exploration. Anyone who have obstructive jaundice, a palpable stone or tumor, or evil stone by cholangiography during the operation, or CBD dilation 1 centimeter in diameter, and or there is a puncture with bile is leaking, right? So that warrants what you can say exploration. So laparoscopic cholecystectomy is there, open cholecystectomy is there, mini cholecystectomy is there, and sometimes we use medications, right, like deoxycholic acid or chenodeoxycholic acid. Okay, that basically dissolve the stones. So, now what tests are done depending on the patient fitness, depending on the anesthesia, they decide. Okay. Laparoscopic cholecystectomy, of course, like it is done by laparoscope, minimally invasive, very small cuts are needed, and they put the laparoscope inside, and they can take the stones out. Okay, due with the help of that. Whereas open cholecystectomy is the previous approach in which like uh, a little big incision is made, and of course from there the gallbladder is approached, and once like they have approached that thing, uh, then they remove the gallbladder. Okay, so this is uh, this thing can be done. So sometimes when they can palpate the stones in the common bile duct, or someone who have a jaundice, or someone who have a very dilated common bile duct, then they do CBD exploration, choledochotomy. So this is how they approach the patient, right? So there are many complications as well of these things, but the complications, of course, there are different type of complications that occur in different type of people. Okay, so this is like all the photographs of the surgeries or different investigations. So, okay, okay, so okay, so that's all, guys, for this lecture. And what is next is like in the next lecture, what we will be doing. We will be doing the continuation of this thing. We will talk about when the stones are in the extrahepatic duct system, okay, or intrahepatic duct system. We will cover, common bile duct stones are called as choledocholithiasis. So we will discuss that a little. And what we will do, yes, we will study about Courvoisier's law, or you can say the uh, gallbladder carcinoma. Okay, in the lectures we are going to cover these things. Of course, I will not talk in the start about um, what you can say the anatomy and physiology. Rather, I will go to the topics directly. So next lecture we will be doing that, and after that, like, we will start some other thing. So thank you so much for listening. I hope you understand. I will see you around.